Okay, so this is our outline. Now, let's start by saying this. We all love surgeries. That's why actually we are doing gyne. And I know it that you guys are just like me. We like sometimes cutting. That's the fun part of it. Otherwise, we would have gone for pediatrics or internal medicine. But if we are here, it's because somehow we like the knife. So, but the question that comes now is it always the best solution? Sometimes it helps, but sometimes also it does not. So that's what now we are going to see here. Now look at this guy. He's called Sir William Osler. That was a Canadian physician. He said that diseases that harm require therapies that harm less. And that's where Hifu stands. That's number one. This guy is considered as the father of modern medicine. Basically, he was the first one who initiated the residency program that you guys are doing now. He was the first one. He was the first one to initiate bedside teaching. This guy. Remember him. It's very important. Okay. Now, look at the surgeries, the type of surgeries that we have. We have the invasive one, we have the minimal invasive, and then we have the non-invasive one. So, somehow, Sir William Osler, by saying it, it's like he was trying to tell us that in the near future, we should be thinking more about doing surgeries without cutting patients. That was basically the message behind his words. Now, when we talk about invasive surgeries, we all know that's what we do usually when we talk about pelvic tumors. What do we do? Laparotomy, myomectomy, hysterectomy. When we talk about minimally invasive surgery, what do we have? The laparoscopy that we do nowadays, hysteroscopy. We have even uterine artery embolization is considered as minimal invasive surgery. We have something that we call nowadays transcervical radiofrequency ablation of fibroid. I don't know if you've heard about it. It's also a new technology that we do. And then, of course, when we talk about non-invasive, what do we have? We have the Hifu. That's so far up to now what is best as something that we can offer to our patient. Okay? Now, what is Hifu, by the way? That's what we are saying. It involves actually high energy focused ultrasound beam. Actually, it's 10 times the more powerful than that diagnostic ultrasound that we use usually whenever we send our patient to go for ultrasound. This one is more powerful. And the power definitely comes with what? Comes with heat. So basically, we burn the tumor, nothing else that we do. So we're talking about a heat that is in between 65 degrees to 100 degrees Celsius. And that's how we manage to burn these tumors. This is the model that we have. I don't know if it's well seen, but when we go there, you have to see it. It's called model GC300. That's the latest one that was produced last year. Actually, we are the first one in the world to be having this. That's the very first model that we had. And then after that, other countries will follow. So that's a new one. We see it there. It has its CPU. You don't have it here in the picture, but over there you will see it. Now, when we talk about Hifu, I've been asked so many times, is it only in China? It's not only in China, it's worldwide. You can even see it here. In Africa, we are the fourth, because it was, first of all, brought in Egypt, Nigeria, and then South Africa, and currently it's in Tanzania. But if you move out of Africa, you can go to Asia. Majority of countries, they have it, and then you can go a bit of, in Europe, United Kingdom is in Oxford, actually, university. Germany, it has it, Romania and all these things, and then you go to Central Africa, Cuba, they have it also. So this is a bit how it looks like. You can have the ultrasound Hifu, or you can have the MRI Hifu. There are two types. Okay, as we have the ultrasound one. But this is how basically it is. You see there, I'll explain to you there live, and then you understand better. Where you have a transducer, there's a concave instrument that you have, this one down here. And then you have, in between the transducer, you see there's a probe, an ultrasound probe. Whenever you go there, you will see it, and then you have water. Water basically is for cooling purposes, and then it's also for better visualization of the structures in there. So this is how it looks like, and then it generates something. The red point you see is called focal point. That's where you have now the maximum temperature that is used now to burn the tumor. So like I was saying, it's non-invasive. Of course, it uses energy that produces something that we call coagulative necrosis. That's how we call now those tissues that have been destroyed. It can be performed under MRI, like I said, or ultrasound guidance. So this is basically how it looks like. You have that transducer that is over there, and then it releases those ultrasound beam. So initially it's wide, and then it goes up to the point, so it's convergent. And then at the top, that's where you have the maximal temperature. But as you get near to the top, you also have some temperatures. That is even why it's a bit technical whenever you are treating a patient. So you have to be careful, especially if the mass is just close to the skin, which means that you will treat the mass and then you will burn the skin. Because the focal point will be at the mass, but the other area just close to the focal point will just be at the skin. So somehow the patient will be getting some temperature, and if she's exposed, or that area is exposed for so long, the skin also burns. So it's a big technical. We have to know really how to treat those patients usually. So this is an example of what you can do there. The transducer is there, and then you have the triangle is what we call the acoustic pathway. And whenever you want to treat, you have to be sure, first of all, that the surrounding organs are not in the acoustic pathway. Because if they are there, for example, we talk about the bowels. If you have the bowels in your acoustic pathway, you risk burning those bowels. So you have to put them out. So your acoustic pathway should be free. It should just be the skin, the subcutaneous tissues, and then straight to your uterus, where you are going to target the fibroid or adenomyosis, because we're in gynecology. So now, indication, we can treat them for, basically it's all types of soft tissues: liver, kidneys, breast, bones, pancreas tumors, and then uterine fibroid and adenomyosis. As we're going to focus on fibroid and adenomyosis only. But the first patient that was treated for osteosarcoma. She wasn't treated for fibroid. But currently, majority of patients that have been treated are female one. Benign fibroid adenomyosis. And they're also talking about other types of indications that are basically more into research: placenta accreta, cesarean scar pregnancy, and all these things. But definitely it's not yet applied, so we won't go for that. What are the benefits? Hifu. It's an effective alternative to surgery, definitely, and medication for fibroid and adenomyosis. Completely non-invasive. You don't cut. You don't give anesthesia. There is no wound care. There is nothing like that. So no risk of blood loss. You have no, sometimes mild pain, but which is manageable during the procedure, and then very few side effects, definitely. Less hospital stay. Usually when we treat them, the next day they are being discharged, and then they can continue with their activity. For those ones who like business, they can go for business. Those who want to go to the gym, they can continue with their gym. No worries about it. Full recovery possible in hours, and at most within few days. Definitely the uterus is preserved together with the cervix and then the ovaries. Significant improvement in quality of life. Definitely less menstrual bleeding, and then relief from these symptoms, urinary symptoms, pelvic pain, and then pelvic pressure. So now let's talk about the fibroid. That's the most common benign pelvic tumor in female. We are talking about 70%. Actually, the epidemiology of fibroid is all over. It's that you've got a bunch of articles that talks about these things. Definitely, black race, always we're talking about it. It affects like 70 to 80% of female of black race. Figo is talking about. Did a study in those women of the reproductive age up to 50 years old, and this was the outcome. 72 to 80% of them somehow will be affected by fibroid. And we are in Africa, and we definitely know that the concentration of melanin is quite high, and that goes with, those. So we are definitely more exposed than even those ones who are manufacturing the machine. So we definitely need this type of technology for improving the life of our wives and sisters and mamas. This is in short some of the risk factors, like I was telling you, because we're not going to go into deep, because it's not about fibroid, it's about Hifu. Let's be clear on that. So you have the race, like I was telling you, black race, most probably family history, they're talking about it, and then other factors where we're talking about early exposure to hormones, those ones who are having early menarche. We're talking about obesity, we're talking about deficiency in vitamin D. That is also usually noted in black race because of the concentration of melanin, and then you have that low sunlight effect. And we're also talking about diet issues, alcohol, and then other issues. And what we know is that more than half of these cases usually are asymptomatic. But sometimes you have, we are talking about 25 up to 50% of women that may experience symptoms. But now the question that comes, if you go to figure questioning the uterine fibroid management and complication and implication or impact of these masses to the fertility. There was an article that was released last year that talked about it. They are questioning it like, okay, is it because it's without symptoms that it does not have an impact on fertility? That's a very big question. We don't have an answer. It's open for discussion. Some of them are saying that definitely, even if it's asymptomatic, we should be thinking about the effect on fertility, especially for those ones who have unexplained infertility with uterine fibroid. So that's what we have we can go and read about it, and then we'll find out. Some symptoms, like you can see, usually heavy or prolonged menstrual bleeding or painful periods, sometimes frequent urination, constipation, pelvic pain, pelvic pressure. You have a longer or more frequent period, and sometimes pain in the stomach area, lower back, and all these things. These are just some of them. You have others. Now, talking about the sub-classification system of this fibroid. Now, when we look at it, what I can just tell you here is that if a patient comes for Hifu, we can treat up to type 6. So it's only type 7 that we won't be able to treat. Actually, type 7 can be treated. It's not like it can be treated, but the problem is that because it's a pedunculated one, it will get detached, and then it will be in the abdominal cavity. That's why we won't go for that. Because once it's in there, definitely you have to go and do laparotomy and bring it out again at the end of the day. So that's why. So it's not beneficial for that. But from 1 up to 6, it can be treated. Yeah. Now that's the thing. Like I was telling you, I don't know if it's even well visible, but basically that's the Figo type 3 myoma. That's what part of what they've called the hybrid type. That type that is in between the intramural and then the submucosal, that has a lot of they've called it a double hit effect on the uterus. Basically, it's concerning the fertility impact on these women that have issues or problem or challenges conceiving. So I'll invite you to read this article. It's very interesting, actually. Unfortunately, I don't think you can read all these impact there. Otherwise, you would have seen it there. But I can share the article with you, and then you go through it. It's very, very nice. Now, talking about the burdens, because it's not only about struggling, conceiving, or menses, or all these things, but you've got also other burdens. Basically, a patient that has fibroid always have other issues, physical issues, always feeling tired because most probably due to anemia, sleeping issues, waking up during the night to change usually pads, social issues, sometimes missing work, it happens, missing school, missing activities, and all these things because someone is, whenever she goes into her menses, it's just a disaster. So she has first of all to stop it. Working issues, peer limiting, or needing to interrupt work flow to address the symptoms. So somehow it's a problem, and we need to see how we can help these women. Now, this is how we used to treat them before. Medical treatment that has proven not always to be efficient, because most of the time either you get withdrawal bleeding, you get these irregular bleedings, you will get sometimes other complications, even cardiovascular issues. Sometimes the treatment won't work at all. Sometimes you just get maybe a very, very minimal reduction of the mass, and then it will come back after you've stopped it. So definitely medically treating fibroid is always very, very challenging. And then most of the time we opt for surgeries, mammectomy or hysterectomy. Mammectomy is usually for those ones who are planning to have babies, and then hysterectomy for those ones who are not planning to have babies. Now, the issue with mammectomy is what? Is that if you repeat mammectomy, definitely what do you create? Risk of adhesions, risk of even compromising the fertility of the patient. Sometimes even we ourselves cause uterine distortion because of the repeated myomectomy, and that's also what we have to take into consideration. So surgery is not always good. It is important, let's acknowledge it, but it's not always the best. We have to think twice, especially if we have another alternative, which is the Hifu that we have currently. Now, that is what they've been saying. Hysterectomy is not your only option. You've got a lot of options, especially Hifu now. That's a very interesting thing here. They're telling you that hysterectomy also has been shown to increase risk of coronary heart diseases. It was these are data from Mayo Clinic research, but if you also go through the Journal of American Medical Association, you also see there was a research that was done 2 years ago that explained the same thing, that if you do hysterectomy to someone who is 35 years old and below, this is how you increase the risk of that patient having coronary heart diseases. So we have to think twice. It's good, like I said, but if options are there to help this patient, let's use those options. Hifu is there for that, so we need to use that. Basically, you can see non-invasive, fertility desire is there, uterine sparing, and it works. Okay, so this is basically a summary of that. Now, research. Last year there was this research that was published, among others, because there are so many that have proved that have been done, and then they've proved the efficacy and safety of Hifu as an option of treatment. Now, this one is very specific because it was done on cases of multiple fibroid. Something that we need to talk about is that we have a high prevalence of multiple uterine fibroid in Africa. There was a study that was done in Nigeria. I think it was like 2 years ago. I don't remember very well, but they talked about it. And even in China, whenever we went for the training, it was also mentioned. Actually, most of the patients that we had for training had a single fibroid. And in Africa, we have many. Firstly, because definitely we delay in seeking for medical attention. That's the first thing, because some of them know it, but they stay with it for years and years and years. And then second, most probably also the race issue also plays part in that process. So this one now was targeting these kind of cases of multiple uterine fibroid, if it was that much efficient compared to the single one, and then it proved also to be working for them. So that is it for the fibroid basically. Now let's talk about adenomyosis, which is one of the other conditions that we manage so well. Now the thing about adenomyosis is very interesting is that, first of all, that's a very complex disease, very, very difficult to manage. If we talk about the data, even epidemiologically, we don't even know. Actually, people are talking about 9% of people affected up to 62, but it's just the interval is just too big. Because the problem with adenomyosis is that, as you all know, basically the way we used to diagnosis was always post-surgery. You go for hysterectomy, and then you take the uterus for histology, and then it comes to tell you the patient has adenomyosis. Now, okay, we kind of diagnose it better now because of the help of MRI. Ultrasound can pick it, but it's quite difficult. It's quite challenging. So most of the time, especially for the focal one that we call adenomyoma, usually it's always confused with uterine fibroid, actually. So MRI actually has come and then it's really helping. But the problem is that how many people have access to MRI, especially in resources limited country? Few of them. I don't know in Tanzania, apart from maybe Dar es Salaam, I don't know Mwanza and I don't know Dodoma and Kilimanjaro. I don't know if there is another place where people can have MRI. So that's one thing about adenomyosis. It's called internal endometriosis. That's how we call it actually. Difficult to treat, we all know that. No clear data on the prevalence rate, we know that. Treatment was not always successful because no matter what we talk about, I don't know, medical treatment, hormonal treatment, I don't know what, it's been proven to help a bit in terms of symptoms relief, but apart from that, nothing much. It helps just a bit, but usually treatment was always, when we used to read, we always used to know that, okay, definitive treatment, TH. You see? But Hifu works superbly well in management of adenomyosis. So we don't need, especially for these women who are willing to have babies, to be thinking about surgery, about invasive surgery. Whenever we have a machine that can help. This is, for example, something that was done and released just early this year, February. That techniques such as UAE, high intensity focused ultrasound, and then these other ones have emerged as promising alternative as reports increased on their efficiency and safety for the treatment of adenomyosis. So this is something that we need to take into consideration, even in our research, in our studies, and all these things. So hysterectomy, I believe personally that it should be first of all sent back a bit in terms of managing these adenomyotic cases. Hifu for management of adenomyosis is recommended by the Asian Society of Endometriosis and Adenomyosis guidelines, and then it's also been mentioned in the Society of Obs and Gyn of Canada. So it's quite gaining some recognition, and I'm sure in the near future, most probably 2 to 3 years, more and more societies will be talking about it. This, for example, one of the examples, unfortunately, is not that well seen, of an MRI with a posterior adenomyosis, where you can see this one here, the hyperintense one is before, and that one is, the hyperintense one is after Hifu ablation, so it becomes dark. That's where we have the coagulative necrosis. Now, when we talk about Hifu itself, first of all, who can be treated, who cannot be treated, we need to know. Okay, inclusion criteria: have a definitive diagnosis of uterine fibroid made by history and symptoms and all these things, plus ultrasound and MRI. That also includes adenomyosis, of course. The size is also very important. It should be greater than 1 centimeter but less than 12. Actually, if it's the guidelines usually are saying that if it's above 8 centimeters, you have to consider treatment, hormonal medication, GnRH agonist plus, and then you go now for Hifu. It at least help in terms of shrinkage, but if it's just Hifu alone, there might be a remaining area that won't be treated because it's quite big, it's quite significant. Body fat of the abdomen wall, okay, it's also very important, but usually these are relative issues, because sometimes we can assess it ourselves and then decide if the patient can be treated or cannot be treated. The distance between the outer surface of the abdominal wall and then the position of the tumor also is very important to take it into consideration, and patient has to be willing. It's very important. You don't treat someone who doesn't understand specifically what it is. I'm telling you this because so many patients sometimes are coming here and then they are telling you that nimeambiwa kwamba kuna mionzi. No, we don't have radiation in there. It's purely ultrasound beam. It's heat and nothing else. So usually you have to explain to the patient. I always tell them that the simple fact that we walk in the room whenever we are treating you should tell you that there is nothing. Because if you were seeing us wearing some, I don't know, shield or protective equipment, then definitely you should ask yourself questions. But that is not the case. So it's something that you always have to tell your patient whenever you're talking to them about Hifu, because they always believe that a machine that looks like, or that has a bit of shape like a CT scan or MRI or I don't know what, always has something that is radiating. Of course, the tumor has to be visible, very important. Without it, you can't decide to go and treat. Otherwise, you just treat something that is not supposed to be treated. Now, exclusion criteria. Okay, definitely, these are cervical tumors and then other gynecological malignancy. You have to clear it out. You basically, up to now, Hifu has not been proven to treat gynecological malignancy up to now. So once you know that your patient has it, you have to think about other alternatives for that. Infection, very important. In case there is an infection, you treat first the patient and then later on you go for that. And then patient with history of surgeries. Now the thing is that this one also is not completely like an exclusion criteria. You have to assess the patient, because we've ever treated someone with 3 previous surgeries. So you assess, you see how big is the scar, and then if the scar is that much thick to be absorbing some energy. If it's the case, then you don't have to go and treat that. Otherwise, you treat the mass and then you burn also the scar. So later on, she'll come with a wound burn, which is also very, very bad. Patient definitely who underwent uterine surgeries in the last 3 months are not eligible for treatment. They have to be to heal completely first and then later come for that. Someone who is having her menses normally cannot be treated. She has to complete first her menses, and then after that we can plan for treatment. Now, what do we do before the treatment? This is basically the routine investigation that we need to do for blood picture, X-ray, echo, ECG, beta HCG. Very important. You need to be sure that the patient is not pregnant, because we've ever had some cases like that the day of treatment, and then you find out that someone has an intrauterine gestational sac. You cannot treat, because if you treat, you cause abortion. So you can't treat such patient. MRI, always very important. It has to tell you whether it is a uterine fibroid only, or you also have to deal with adenomyosis. The size, sometimes some masses are not seen through the ultrasound, and then MRI helps, so it's for a better visualization also of the structure. Speculum examination, very important, because you never know what you may be having there at the level, at the side of the cervix. And pap smear if you are suspecting that something is not okay. Simulation is very important, because after you've done your MRI, you need to take the patient over there. Actually, it's simulation that tells you now if the patient is eligible or not. Without a simulation, you can't say that the patient is not eligible, unless maybe she's on her menses or other things. But if she's stable, you have to do the simulation. You have to be able to put your acoustic pathway on the right part. You have to be able to push away the bowels. You have to be able to see the mass, and then you can now tell the patient that we can treat you or we cannot treat you. And you have to explain why. That's it. Now after that, you have to do bowel preparation. The big enemy of Hifu is gas and fluid. So you have to do bowel preparation so that at least you minimize those things in the bowels. That's it. And then of course, she has to consent for the treatment. And before the treatment, what do we do? Basically, there is what we call conscious sedation. That's what we use. We don't have anesthesia. We just give them, usually we give them analgesia and then a bit of sedation. So usually we mix fentanyl and midazolam. That's usually what we have, and that's what we use. That is what is advised. So the patient always has to be awake. You have to be able to talk to the patient, because she has to be able to tell you in case she feels pain somewhere, she feels numbness, she feels what, so that you can also query maybe some treatment or some mass that is compressing maybe one of the nerves, and you have to be careful with that. So it's very important not to give anesthesia to these patients, because they have to be reporting to you. You have to be able to communicate with your patient whenever you are treating her. So during treatment, it's quite normal to feel a warming sensation in your pelvic region. In the usual event, you feel pain, you can press a safety button, it happens, or you can just shout for help. Or usually, sometimes also, like for us here, we have a nurse who is always there beside you, and who is always trying to reassure you and then to report after the treatment. Follow-up, usually we do the follow-up. The first three months, patient has to come. After that, she comes after 6 months, and then after that, it's 6 monthly she will be coming. We, based on research, always expect that you have 45% of shrinkage, usually after 3 months, and then up to 6% of shrinkage after 6 months. But this, of course, is also based on the size of the mass. Because if you have a mass of 6 by 5 and you have a mass of 8 by 8, definitely you won't expect the shrinkage to be almost the same. But the most important thing is that you need to be treating your patient first. Once you treat your patient, then you can do a proper follow-up, and then you see if there is a response. So basically that was it. These are some of the references that you may be having. Thank you for listening. Now, if there are questions, we can answer them, and then after that we will go and do we'll go and pay a visit to the machine over there. Thank you.
Let's say you have 10 nodules. In one sitting, how many can you deal with?
Oh, okay. Now, that depends on how big they are first. You may be having a patient with multiple, maybe 10, but you'll be surprised that they are small. 3 centimeter, 2 centimeter, those kind of things. So definitely that one, you can treat it quite well. You can treat all of them. Now, you can have some cases where you have quite big fibroids. We've had one that was where the uterus was even above the umbilicus. Now, for that one, there is one thing that you have to tell you. You do not treat anything that is above the umbilicus. So for those kind of cases, what we do is that we treat basically what we have down there. We treat it, and then we give a patient some time. So we have a case that we did like that. We've treated her now. She's just on follow-up first, until we'll have the uterus size that will go down, that will be below the umbilicus, and then she comes back, and then we treat the remaining ones. So it depends. It's on case by case. We usually assess, and then you see. That's how it is here. That is also why the simulation now is very important. That's why we do the simulation, and after the simulation, you have to be able to tell the patient that, okay, maybe we can't treat you completely. Now, if you agree, we go for that. If you don't agree, then maybe you go for just an invasive surgery.
Thank you for your nice presentation. I have 3 questions. First of all, you didn't tell us about the session per hip session. How many sessions will the patient have? Only 1 session? Okay,
one session.
1 session.
Most of the time, 1 session.
Okay, assuming if that patient, she is having more than 1 fibroid, for example, maybe both of them, they are intramural but in different position. How about the focus for the machine? Will it be only single focus to hit them all at once, or will be different focus point?
Okay.
And number 3, what about the effect of Hifu for the submucosal myoma versus endometrium preservation for the fertility?
Okay. Second question first. Definitely, your focal point always moves. Always. Always. If you have 2 myomas, if you have 3 myomas, you always have to go and look for that myoma. Okay? That is why it always moves. You won't have a fixed focal point where you treat all the myoma. That doesn't exist. Yeah. So after you are done treating one, you have to locate the second one, and then you start making your plan. Usually we cut them into slices, and then you treat.
The same session?
Yes, the same session. If you can treat all, you treat all. If you can't treat all, then you have to tell the patient why you can't treat all and what is next for her. Like I told you, we have a patient who was treated who had the first session, and she's supposed to come back for a second one because she had some fibroid that were quite high, and we can't go up to that far because we are definitely going to damage the bowels, even the stomach or something. So we can't go there. You see? Yes. So this is how we deal with it. So your focal point always moves. Either it's foot, head, left, right. Always moves. Now, talking about submucosal myoma and
Endometrium.
yes. Now, when we treat, usually when you have your mass, wherever you put your focal point, the distance between your focal point and then the edge of the fibroid should be at least 15 millimeters. If it's too closer, you burn the endometrium. If you burn the endometrium, basically, definitely you know what will happen. The scar, the uterine synechia, and all these things. So at the end of the day, you are actually causing more damage than you're helping that patient. So if you're not comfortable treating submucosal myoma by using Hifu, it's better to go for hysteroscopy. So for the submucosal myoma, it's a bit technical, but it works well. Sometimes, for most of them, especially for those ones that are quite small, after you've treated it, after sometimes we call it, we say that, okay, the patient has delivered fibroid.
This knowledge, we have to explain to the patient it's a safe treatment for the patient. We need to improve the amount of patients in our hospital.
Definitely.
I think we must continue learning more and explaining more to the patient.
Yeah.
Because it's a safe, the patient are not bleeding, we don't need transfusion, we don't need any problem. I was in the first time when you were starting, it's really safe. Without the risk of anesthesia, without the risk of infection, and it's really a nice procedure. Thank you for your presentation.
Thank you.
Okay, thank you for a nice presentation, well elaborated. I think that it has helped us, junior ones who are going now to be in the field. But I have some question or some additional points. Based on the patient whom they say that they are going to be benefit for HIV. They say that the obese ones, they are not here. They say that the obesity is a limiting factor for HIV. I don't know the obese one, how can we offer, or we will go for another option. And the another one, they insist that we must be sure only blood supply on those myomas which are there, that if there is high blood supply, they don't respond properly. But my question is on fertility part. Fertility part is for those who have maybe they undergone HIV treatment and they have maybe subserosa, and those who undergo HIV and they have submucosa. How are they going to try for fertility? How long are they going to try for fertility? And another question is based on the recurrence after treatment of HIV. Is there any possibility of recurrence? And after the recurrence, is there any possibility of that patient to get another exposure for HIV? Thanks.
All right. Yeah. Thanks for the questions and contribution. First, let me talk about the obesity and as an exclusion criteria. It's not an absolute exclusion criteria. We've treated obese patients, by the way. The problem with these patients is that sometimes the fat absorbs the energy. So you need to be very, very careful when you treat them. So actually, I've never seen a patient who has been put aside because she was obese. Maybe because I've never seen a patient who is morbidly obese and who has come for that. But we've treated quite some patients who have high BMI, especially, remember, we're in Africa, and then, yes, our population is, different from Asians, where it is. So you have quite a big number of people who have. So if it was as an absolute criteria, I'm sure more than half of our patients will be put aside. So usually that's why I said again, that's why we do the simulation. Simulation is there for that purpose now, to be able to assess if you can treat this case or if you can't treat. That's the thing. Now, talking about the high vascularity of the masses. Now, what I can just tell you is that it's not like they don't respond well, but you need to treat them for long. That's the thing. Now, what can you do to try to bring it down a bit? That's why we use oxytocin. That's number one. Number two, for these cases, it's not actually only the vascularity, it's also some of the changes. Sometimes you may be having a lot of calcification in the fibroid. That one, you can't even treat that one. You can't. Or you have liquid changes in the fibroid. That one is also very, very difficult into treating. So these are the cases that requires a lot of time treating, but you can treat. machine behind here, but before the machine, let me introduce you to the team. So for this is the team here. We have the doctors, Dr. Juliet, who's a radiologist. There is Dr. Ruta also. He's not in now, and then me. We are three, and then we have Mr. Mgaza, the radiologist. We have Mr. Kamala Pia, another radiologist who is most also of the time here, and then with the MRI. And then we have our nurses here, Sister Mariam and Sister Beatrice. So this is basically the people who are here, as we are working as a team, all of us here. So, like I told you, you're free to walk wherever you feel like, because there's no radiation. It's basically heat ultrasound thing. This is the machine itself. The CPU is the one behind there. That's what controls everything. Temperature, power, and everything. That's the big thing behind there. And now that is the control. That's what we use to treat. Why do we have four computers? Maybe you can see so that you understand. This is the ultrasound. This is the ultrasound. That probe that you see it there, I'll show you. This was the ultrasound, and this one is the ultrasound. This is the ultrasound. This is our system, our Afia box system. This is it here, to have the files of the patient and everything. Plus, we have the software that reads the MRI. So whenever we are treating, we always have the pictures of the patient here, the MRI image. This is here. Now this is a system for treating now. And this is the control system, this one down here. This is basically our file. The patient we've treated so far up to now, you can see 35. So we keep them there, we keep the record there. If we decide maybe to go, okay, for a demo. So this is our system now. This is usually how it appears. And that's how you treat. Now you have here, your focal point is there. That's the focal point I was talking to you. And this is the acoustic pathway. Your transducer is down here, and you have your probe here. Now, before we continue here, let's go and see the machine first, and then you'll come back, you see something. Guys, tunaomba tushushe transducer eh? Eh? So, okay, this is our bed, okay? Now you have, this is the transducer, what we're talking about, that concave thing. This is it here, and that is what generates those beams. And you have the ultrasound. The ultrasound is basically for us to see, to keep on seeing the image in real time whenever we are treating. This place is usually filled with water. Water that is quite cold, usually it's around 10 degrees Celsius, that water, for cooling purposes and then also for visualization of the image. Usually the patient lies, the head is there and then the legs are over there. And then the abdomen is here. That's how we treat now. And now you can adjust. Tunaweza shusha transducer. Just zaidi. Okay. Probe up, naomba. You can also adjust your probe. You see. Rotation. Probe rotation. Eh? Yeah, but usually we use distilled water. That's the best actually. Rotation? No. I'm not a kutoboa.
Manipulation ya bowel mnafanyaje?
Okay, good. You see? The transducer is tilting sometimes, and then the probe is rotating. So we have so many ways. Now, there's something very interesting. Someone asked, bowel, how do we push? We usually use this. Yes. Sometimes we don't need to use this if your transducer is too close, and then if the mass is big, sometimes automatically the bowel just goes away itself. Now, in case it doesn't go away, you use this balloon. Just put it somewhere. Usually we put it this way. Put it here. And then it goes. So now you can add. Can I have that remote?
What?
The remote, there's a remote there. With the blue light.
Oh.
Yeah. So you see, you can use this remote. You can add water, you can reduce water. It depends. For example, here it's going down. You see? Yeah. In a compress, it's here. It's here. It's here. The patient is on prone position.
Okay.
And it's here.
So,
Yes. So it's either you add more water or you reduce the water, and then it also has. Yes, you push, you know.
Push,
yes, it's just like if it's here,
okay.
if you add more water,